Hello, everyone. I'm Sheila Maitra, Professor of Intensive Care working at the Tata Memorial Hospital in Mumbai, India. I'm going to give you a bit of a background behind doing the COVID steroid 2 trial. Now, as we all know, the COVID-19 pandemic has resulted in unprecedented challenges in our healthcare system, resulting in several patients turning positive and high mortality, and it continues to be an ongoing global challenge. Now, patients with COVID-19 are characterized by severe pulmonary inflammation and hypoxemia, and this often leads to high oxygen flow, oxygen, mechanical ventilation, and also further disease progression, often requiring other organ support, hemodynamic support, dialysis, etc. So the question was that about steroids in viral pneumonia. And if you look at steroids, the role of steroids in viral pneumonia, there are not many studies, many observational, some retrospective, and few randomized controlled trials. And this was a systematic review and meta-analysis that looked at the effects of corticosteroids on mortality of patients with influenza pneumonia. And this included 10 randomized controlled trials, close to 6,500 patients. And it actually showed higher mortality in those patients who received corticosteroids. Now, do steroids work in the other coronavirus pneumonias? And this is interesting mixed results. And if you look at the SARS, where they tried high dose pulse versus non-pulse COVID steroid regimens, and high dose was more than 500 milligrams of methylprednisolone that was given to in this study in 77 patients. And what they found was that the high dose methylprednisolone given early in patients with SARS actually resulted in lesser oxygen requirement, lesser progression of the disease, and better clearance in the x-rays of these patients. On the other hand, when they looked at corticosteroid therapy for critically ill patients with the Middle East respiratory syndrome, and this was done in 14 intensive care units in Saudi Arabia, which was led by Professor Arabi, what they found was that there was no difference in the mortality when patients received corticosteroids or not. In fact, patients who received corticosteroid had more delayed clearance of the MERS virus. So really mixed results. So is there a rationale for giving steroid therapy in COVID-19 patients? Yes, it's a hyperinflammatory state. There's a so-called cytokine storm. Almost a third of the patients present with circulatory shock, and you have an ARDS type of picture. And there's this very nice editorial that was written by Professor Arabi et al. On 10 reasons why corticosteroid therapy reduces mortality in severe COVID-19 patients. And we know about this Spanish trial, which looked at dexamethasone treatment for acute respiratory distress syndrome. And this was a multi-center randomized controlled trial, 277 patients. And they looked at 20 milligram and 10 milligram dexamethasone for 5 days each, compared with placebo. And they actually found a reduction in mortality in those patients who received the dexamethasone treatment. So this was a kind of background that we had. And then there were several trials across the globe that were looking at corticosteroids for patients with COVID-19 and severe hypoxemia. And we did the we started the COVID steroid trial with low dose hydrocortisone in patients for COVID-19 and severe hypoxemia. And this was giving 200 milligrams of hydrocortisone versus placebo. And these were in patients with severe COVID-19 and severe hypoxemia who were either invasively mechanically ventilated or at least receiving 10 mils of 10 liters of oxygen. However, when this trial had just about started, it was planned for 1,000 patients, but when we had completed just 30 patients, the recovery trial was published, and this study, like many other studies, had to be prematurely aborted. And with just 30 patients done, we could not make any conclusions on either the efficacy or harm with using hydrocortisone in COVID-19 and severe pneumonia. And of course, the recovery trial, which was published in the New England Journal of Medicine. This was a landmark trial, large number of patients, and which used 6 milligram of dexamethasone for daily for 10 days in patients with COVID-19. And there was a clear mortality benefit in those patients who were invasively mechanically ventilated and oxygen dependent. However, there was no difference in mortality in those patients which did not require respiratory support. And this was a practice changing paper. And subsequently, people started across the globe, clinicians started using dexamethasone, the steroids for treating patients who were oxygen dependent with COVID-19. And subsequently, the WHO also commissioned this meta-analysis looking at the association between the administration of systemic corticosteroids and mortality among critically ill patients with COVID-19. And this meta-analysis included about 1,700 patients and patients who received hydrocortisone, methylprednisolone, dexamethasone. 7 trials were included, and there was a clear benefit in mortality benefit in those patients who received corticosteroids versus those patients who did not receive corticosteroids. And subsequently, the WHO recommended the use of dexamethasone for patients with severe and critical COVID-19 was recommended. However, there were still several questions that were unanswered. There wasn't a head-on comparison between the different corticosteroids. And we knew that steroids are better than placebo in COVID-19 patients who are oxygen dependent, but which dose would be superior was still not known. And the recovery trial used 6 milligrams of dexamethasone. But the question was whether there was a role for a higher dose of dexamethasone than 6 milligram. Could that be beneficial? So if you look at the recovery trial, of course, used 6 milligram of dexamethasone. But if you look at the remaining 6 trials in the meta-analysis, they used daily doses of glucocorticoids, which were higher than 6 milligram of dexamethasone. And this was a median of almost 12 milligram, interquartile range of 6 to 16. And I've already shown you the Spanish trial, which showed that higher doses of dexamethasone have been beneficial. And this was, of course, in non-COVID ARDS. In addition to this, pharmacological studies have also suggested dose-dependent activation of the corticosteroid receptors with increases doses up to 60 milligram of prednisolone. And this is equivalent to about 12 milligram of dexamethasone. So taken together, there is a justification for giving higher doses of dexamethasone than 6 milligram, and this may be beneficial. However, giving higher doses of corticosteroids, there's also concerns about adverse reactions with the higher doses. There were, especially with infections, there were concerns about activation of tuberculosis and other invasive fungal disease infections. And we experienced this in India actually during the second wave, where there was a mucormycosis epidemic. So how we went about this post-recovery trial is we contacted the investigators from the various sites who were involved in the COVID steroid trial, and we asked them about their clinical preference for using steroids post-recovery. And almost all patients, except about 1.6% of the clinicians, said they would never use steroids, but they would either always or mostly use steroids or use steroids sometimes. So definitely the practice has changed post-recovery. And we also asked them about their trial preference post-recovery. And we gave them various options, dexamethasone compared with hydrocortisone, different doses of dexamethasone, 6 milligram versus 12 milligram, 6 milligram versus 20 milligram. And the highest preference was for the comparison between 6 milligram and 12 milligram of dexamethasone, which is what we used in this trial. And these were responders, 237 responders from the European countries and India, who were part of the initial COVID steroid trial, who gave this response. And then we went about planning the COVID steroid 2 trial, comparing 12 milligram dexamethasone with 6 milligram dexamethasone, looking at the benefits of mortality benefit with days alive without organ support, and of course assessing the harms, whether there were any serious adverse event reactions or any mortality. So I'll stop here and ask Professor Bala to kindly continue with the methods. Thank you.
I'll just get my screen share here. Oops. Can you all see the slides?
Yes, that looks great, Bala. Thank you.
Thank you. Sheila, thank you for that. Once again, Rob, thank you for the opportunity to report the trial at the CCR meeting. And again, thank you to Anders Sperner for his leadership of the trial. As Sheila mentioned, the aim of the trial was to evaluate the efficacy and safety of higher dose dexamethasone in hospitalized adults with COVID-19 and severe hypoxia. And the hypothesis being a higher daily dose of dexamethasone, 12 milligrams, as compared to the currently recommended daily dose of 6 milligrams, would increase the number of days alive without life support at 28 days after randomization. The study was sponsored by the Collaboration for Research in Intensive Care in Denmark and by the George Institute for Global Health in Sydney and New Delhi. The study was funded by Novo Nordisk Foundation in Denmark and the Rigshospital Research, Critical Care Research funding stream. And that, as Sheila mentioned, the trial design was informed by a survey conducted of the COVID steroid 1 trial, which is performed post-recovery. And the key messages really were that the clinician's preferred corticosteroid was dexamethasone. There was a 50% of the clinicians preferred 6 milligrams, while a third of clinicians preferred doses greater than 6 milligrams. And most of them were comfortable in enrolling patients into a 6 versus 12 dose comparison trial. The trial was investigator-initiated. It's a pragmatic, blinded, parallel group RCT, and it was an international trial conducted in Denmark, India, Sweden, and Switzerland. The inclusion criteria were adult patients who were hospitalized with confirmed SARS-CoV-2 infection and requiring one of the 3 criteria, as in they require to have supplemental oxygen at least at 10 liters per minute, or non-invasive ventilation, or invasive mechanical ventilation. The exclusion criteria were if patients were requiring systemic corticosteroids for other indications than COVID-19 in doses higher than 6 milligrams, or had used corticosteroids for more than 5 days for COVID-19 prior to randomization, or those with invasive fungal infection or active tuberculosis, or known hypersensitivity to dexamethasone, and pregnancy. Any of these were deemed exclusions for enrollment into the trial. The trial treatments were dexamethasone 12 milligrams, which was supplied as dexamethasone phosphate, or 6 milligrams, again, in the same formulation, and these were suspended in sodium chloride solutions. And in sites where dexamethasone wasn't available, betamethasone was allowed, and we discouraged other immunosuppressive agents. However, following the REMAP-CAP preprint, tocilizumab was allowed as part of a standard treatment for COVID-19. The interventions were administered in a blinded fashion. They were, as you can see, they were administered as a masked bolus injection, a total volume of 5 mL IV. And this was prepared by a team of unblinded trial staff who weren't involved in the care of the trial patients or in data collection or data entry. And they were prepared from shelf medication at the local hospital pharmacies. And the patients, the treating clinicians, and the trial personnel were blinded to the trial treatment as well as to the allocation sequence. The duration of trial intervention was for a maximum of 10 days from randomization or until hospital discharge or death if earlier. If the patient had received dexamethasone for COVID-19 prior to enrollment, the intervention period was shortened so that no patients received dex for more than 10 days as per the protocol. And within the hospital, following the initial treatment, if they were discharged to another department which is participating in the COVID steroid 2 trial, then the allocation was continued for up to 10 days. But if they were discharged or transferred to a non-participating hospital department, then the intervention was stopped. The randomization was password protected through a web-based interface with permuted blocks of varying sizes and stratified by trial size, age greater or less than 70, and use of invasive mechanical ventilation at the time of screening. The trial was overseen by the CRIC in Denmark and by the George Institute for Global Health in India. And all the operational processes and statistical analyses were coordinated by the CRIC unit in Denmark. There was a web-based database. There was a pre-specified data monitoring plan, a pre-specified source data verification plan, and we had ethics approval at all sites pre-enrollment. And in India, as part of a requirement for all international sites, we also had to get Health Ministry Screening Committee approval, which we did. And all the consent procedures were as per local jurisdictional requirements. And the funders had no role in the statistical analyses or the manuscript preparation. The primary outcome was number of days alive without life support, that is invasive mechanical ventilation or circulatory support or renal replacement therapy at 28 days after randomization. There were a number of secondary outcomes, and these were day 28 mortality, day 90 mortality, and serious adverse reactions at 28 days, defined as either new episodes of septic shock, invasive fungal infection, clinically important GI bleeding, or anaphylactic reaction to dexamethasone. The sample size calculation was based on a mortality rate of 30% would die and 10% would still be on life support at 28 days in the control group. And so based on that, we estimated that we would get a 15% relative risk reduction in 28-day mortality combined with a 10% reduction in time on life support. And at an alpha of 0.05 and a power of 85%, we estimated a sample size of 1,000 patients, 500 in each arm. A protocol and a statistical analysis plan were published prior to database lock. As you can see there, it was published in Acta Anesthesiologica Scandinavica, and it was the trial was registered on clinicaltrials.gov and also on the clinical trials registry in India. There was a data safety monitoring committee, which was an independent committee with a charter, and an interim analysis was completed after the first 500 patients had been followed for 28 days. And the first review provided a recommendation of continuing the trial without modification. These were the key study dates. We commenced the trial on the 27th of August 2020, and the last enrollment was on the 20th of May 2021, and 28-day follow-up was four weeks after that, and a database lock towards the end of June, and followed by an immediate investigator presentation and a manuscript submission 4 weeks later, and then the first presentation by Anders at the ESICM Lives meeting on the 6th of October, and of course today's Critical Care Reviews meeting. Thank you. Over to you, Anders.
Thanks, Bala. Can you see my my screen?
Yes, that looks great, Anders. Thank you.
Thanks a million, Rob, for hosting this presentation and hopefully very interesting and enlightening discussion. Thanks a million, Sheila and Bala, for a very, very nice build-up to the results, which I'll present in the next 10 minutes. So we screened 1,414 patients, excluded 414 of those primary because patients had already received glucocorticoids for 5 days. Some did not consent, and others were to receive higher doses of steroids for another indication. 1,000 patients were randomized. A few were withdrawn because of lack of consent. Some of these prior to the first dose of trial medication, some during follow-up. Only a single patient was lost between day 28 and day 19. So therefore, we present data on 97% of all randomized patients. Patients were primarily enrolled in Denmark, 50%, 1/3 or a bit more in India, and the rest in Sweden and Switzerland. Most patients were enrolled in an ICU, some in a normal ward, and a few in emergency department or HDU. The time from symptoms of COVID to hospitalization was 7 days in both groups, and we enrolled patients 2 days after hospital admission in both groups. Some baseline characteristics. Patients were aged 65, mostly male, weighing 80 kilos. They had the sort of expected coexisting illnesses: diabetes, ischemic heart disease, heart failure, COPD. This is the use of oxygen supplementation at the baseline. 55% received oxygen on an open system with a median flow of 23 liters per minute. A quarter was on non-invasive ventilation or CPAP with an FiO2 of 0.60, and 20% were on invasive mechanical ventilation at the time of randomization with an FiO2 of 4.60. Some co-interventions registered at baseline. So most patients had already received dexamethasone as this was allowed at the time of randomization, and this had been given for 1 day median in both groups. 2/3 received remdesivir and 10% received an IL-6 inhibitor. This is the use of the trial medication after randomization. We intervened with the trial medication for a median of 7 days in both groups, and only 2% in both groups received open label steroids during the intervention period. So the primary outcome was days alive without life support, and this is the distribution of the primary outcome in the two groups, shown here as stacked horizontal bars, with red being worse outcome. So the darkest red there is 0 days alive without life support at day 28, and blue represents better outcome, and the darkest blue is 28 days alive without life support at day 28. And already here you may see that there may be a difference between the two groups. So these are the medians in the two groups. So 22 days median days alive without life support in the 12 milligram group versus 20.5 days in the 6 milligram group. The primary analysis was one of adjusted mean differences, which was 1.3 days favoring the 12 milligram group with a 95% confidence interval ranging from 0, so no difference, to a 2.6% more days alive without life support in the 12 milligram group. The p-value for this analysis was 7%. We assessed the primary outcome in several subgroups, 7 in total. These were predefined. And as you see, there was no statistical significant heterogeneity in the intervention effect in any of these subgroups. Most of the point estimates lie there on the benefit for 12 milligram side, with the only potential point estimate pointing the other direction was the use of an IL-6 inhibitor at baseline, but small numbers, so quite uncertain results. We also assessed days alive without life support at day 90, and this was 84 days in the 12 milligram group versus 80 days in the 6 milligram group, giving an adjusted mean difference of 4.4 days. And here we present 99% confidence interval because of multiple testing. This ranged from -1.6 6 days. So a slight reduction in the number of days alive without life support to up to 10 days, more days alive with life support with 12 milligram group in the 12 milligram group. Days alive and out of hospital, also at day 90, so 62 days in the 12 milligram group versus 48 in the 6 milligram group. So potentially, at least on the medians here, a large difference. The adjusted mean difference was 4 days with a confidence interval ranging from -1 to up to 10 days, more days alive out of hospital in the 12 milligram group. These are the time to death analysis showing a Kaplan-Meier plot and the corresponding hazard ratio, which is actually a post-hoc analysis that we were asked to do during the review process in the journal. The two landmark mortality outcome assessments were at day 28, where 27% of the 12 milligram group patients had died versus 32 in the 6 milligram group, giving an adjusted absolute difference of -5% favoring the 12 milligram group. Again, here 99% confidence intervals are giving, ranging from -11% absolute difference, so a quite large mortality difference, up to 2% mortality increase with 12 milligram group. The same goes for mortality at day 90, so 32 in the 12 milligram group versus 38 in the 6 milligram group. Again, an adjusted difference of -5% with a confidence interval, again, crossing 0 for -12, so a rather large mortality reduction with 12 versus up to +2%, so a slight increase in mortality with a higher dose. As pointed out by Bala, serious adverse reactions was a predefined outcome that we assessed daily up to day 28, and this is a composite outcome. So these are the number of patients with one or more serious adverse reactions, being 11% in the 12 milligram group versus 13% in the 6 milligram group, and adjusted difference of -2, ranging from -7 to +3. These are the 4 specific adverse reactions we asked for daily. Most of these reactions were new episodes of septic shock in around 10% of patients in each group, invasive fungal infection around 4%, and severe GI bleeding in around 2% of patients. No patient had an anaphylactic reaction to dexamethasone. In addition to the registration of serious adverse reaction, we obviously had the more spontaneous reporting of any serious adverse events. So if you combine these two, so the number of patients having either a serious adverse reaction or a serious adverse events, that was 21% in the 12 milligram group versus 25% in the 6 milligram group. So to conclude, I think it's fair to say that we did a high quality trial. It was blinded. We had few violations. The vast majority of patients were analyzed, and we used 90-day follow-up for this report. By enrolling patients both in Europe and in India, we enrolled patients with different characteristics, risk factors, practice patterns, and healthcare systems, potentially increasing the generalizability of the results. The sort of narrow statistical conclusion is that dexamethasone 12 versus 6 milligram did not result in statistically significant more days alive without life support at 28 days in patients with COVID-19 and severe hypoxia. There are obviously issues to discuss, and I'm sure we'll touch upon some of these. It's quite evident now that there appear to be benefit from anti-inflammatory effect on top of that of 6 milligrams of dexamethasone, as shown with the use of IL-6 and JAK inhibitors. We believe that the COVID steroid 2 trial results are most compatible with overall benefit from dexamethasone 12 versus 6 milligram. We will inform clinicians and patients further by doing a pre-planned patient analysis. We are collaborating with 4 other trial groups who have done sort of similar trials in a prospective meta-analysis, and we will follow the patients in COVID steroid 2 up to day 180, which will be around the 20th of November, assessing their mortality and health-related quality of life. I think this trial was a magnificent undertaking. There's obviously heaps of people involved, and therefore heaps of people to thank the staff at CLIC and the George Institute in Sydney and New Delhi, all site investigators and research staff, patients, relative clinical staff accepting a trial during very difficult circumstances. Also sort of the auxiliary staff being monitors, those funding the trials, the people doing all the legal stuff, ethics committee, medicines agencies approving the trial very fast under challenging circumstances. I'm proud and happy to announce that the paper is published now as we speak in JAMA. With that, I will stop sharing and give the word back to Rob. Thank you.
Anders, thanks so much. Bala, Sheila, and the entire team, congratulations. A fantastic trial, magnificent trial under extremely difficult circumstances. We're going to cross to Aberdeen now and to Marion Campbell to hear her editorial. Really looking forward to this, Marion. Over to you.
Thanks, Rob, and thanks, Anders and the team. Superb effort. So I'll share my screen. Here we go. And I'm going to full screen. Can I just check, are you seeing that okay?
Yes, that is perfect, Marion. Thank you.
Super, excellent. Well, thank you so much for giving me the opportunity to talk about this trial. I find it absolutely fascinating. And really, I want to start with the first, well done, superbly delivered trial, really difficult circumstances. So anything that I've picked up and seen over the course of reading this trial is really just, you know, around the edges. Really, the most important thing is that this is a superbly run and executed trial. My plan is to have a quick overview of the methods, have a look at the results, pick a few items for discussion that maybe we'll talk about in the group discussion afterwards, and then a little bit on interpretation. So I think you will share with me that the methodology was incredibly strong. We've heard already very strong rationale for the study question, good rationale for the study population who should come into this trial. It was a large sample size, well informed. The control event rate was informed by previous studies. Allocation concealment was superb and supreme. It was concealed even up to and after the drafting of the abstract. And that really is taking making sure you have no scientific bias really to the extremes. And I would really like to thank the trial for that. So very strong methods and analysis. And it was also benefited by strong sensitivity analysis to really test out the results. Again, just a quick word about the recruitment. It was multinational, 31 sites between Europe and India. And the things I would look out for here is there any evidence that recruitment is dominated by any one site? Therefore, is there any bias within it? I've included here the graph of the recruitment. And as you can see, it's a good distribution of recruitment across sites. There's no one site that's dominating, so that gives me reassurance that generalizability is good and that it's not being driven by any particular management pathway at any one site. And you did recruit up to the planned sample size. So again, I think it's really top marks in this. You really did, you set out what you did and delivered it. So we've heard from Anders what the result is. We had this composite outcome, number of days alive without life support, and that's invasive mechanical ventilation, circulatory support, or a renal replacement therapy. And we have the 22 days in the 12 milligram group against the 20 days in the 6 milligram group. And as you can see, the confidence interval runs from 0 to 2.6, and as ever, a tantalizing statistical significance. And 28-day mortality, 5% difference in mortality, which by any factor is an important difference. Again, if you look at the confidence intervals, very much verging towards benefit and crossing the line of unity to 1.08. And then the third element was, does this have additional harm? Are there serious adverse reactions? And here again, we see a lower rate in the 12 milligram group compared to the 6 milligram group. But, you know, again, not quite statistically significant, and that's similar out to 90 days. So as we've heard, the effect sizes are all in a positive direction, but it's not statistically significant. So what should we conclude from that? I think a really good place to start, let's unpack a really nice paper that was in the New England Journal in 2016, written by Stuart Pocock and Greg Stone. Stuart's one of the high-level trialists. Is, you know, what should you do if the so-called primary outcome, inverted commas, fails? What should you do? And it really goes through a sense of, you need to ask yourself quite a few questions. You know, is there indication of potential benefit? What about power? Was the primary outcome appropriate? And so on. So, you know, you want to go away and read this for yourselves and take it as a little checklist to go through the trial. I'd encourage you to do that. But I'm going to pick out a couple of things that struck me as I read it and that I think might be worthy of discussion in the wider group. The things I'm going to look at are the primary outcome itself. Look a little bit closer at the population who got into the trial. Ask that question about statistical power. I want to drill down a little bit about the use of dexamethasone ahead of randomization. Talk a little bit about these p-value thresholds. Ask the question that probably everybody on Twitter wants to know, is Bayesian reanalysis the silver bullet? A little bit about that, and then talk about what might be tagged this is a negative trial. I'll go through each of these in turn just over the next few minutes, just to start that discussion. So the number of days alive and without life support. And again, clinically very sensible. I can see why it was chosen. And the median is 22 days versus 20.5 days. However, there is ceiling effect in this. If you look at the top end of the interquartile range, each of them is 28. So even from that, we know that at least 25% had the very highest value. And actually, it was over 40% had returned the highest value possible of 28 days alive and without life support. So already, you're giving any type of analysis process a hard job to try and discriminate between 41% of the trial population who had the very best result possible. But ceiling effects continue out to 90 days, and certainly the team tried an analytic approach to try and help with that. But really, I think this is providing a major problem for any analysis strategy to detect difference. You're dominated by a ceiling effect. So actually, I feel the primary outcome is not helping you in this trial. And likely what we need to do for interpretation is to look to the other outcomes to help inform our judgment. So it might be worth a discussion about how we ended up with an outcome that had such high ceiling effects. And I want to look a little bit at who got into the trial. And we heard that, it is really trying to look at those with severe hypoxia, but there is a range of severity presented. So we have 55% who had the supplemental oxygen. We had about 25% with non-invasive ventilation or CPAP, and we had about 20% who were already on mechanical ventilation. I suppose my question would be to the clinicians was what is or was the real target? Was it the whole spectrum of more severe disease? Or was it actually that, ideally you'd have looked at one end of the spectrum? And what really sort of made me question that was you saw the subgroup analysis that showed the consistency of effect. But if you look at the actual estimates of size, those who were originally on invasive mechanical ventilation, their primary outcome was 9 days in the 12 milligram group versus 2.5 days in the 6 milligram group. Whereas if you came into the study without mechanical ventilation, it was 28 and 28. So again, you see the ceiling effect is almost completely confounded with the level of severity of supplemental oxygen. So again, my question would be, did you, somehow confuse the picture even more by having such a wide spectrum of what could be called severe disease? And again, that's maybe worthy of a little bit of discussion afterwards. The power question. So this is, what we often see is an issue with trials that don't come up with a significant result. I thought the underpinning sample size calculation was very robust. It was looking for a relative difference of 15% in 28-day mortality, and that would have been effectively absolutely down from 30 to 25.5%, and then looking at a 10% down to 9% in life support. And actually, you saw a mortality difference of, approximately 5%. So, you may have been on the cusp of power issues, but actually, I feel the sample size was probably okay. I don't think statistical power is your biggest issue in this study, but, obviously a bigger trial might have helped you. But in the light of a primary outcome with ceiling effects, I don't think the power would have helped you out here. So actually, I'm not so bothered about the statistical power in this study, as maybe some others would be. And a couple of points about the prior use of dexamethasone. So rightly, you allowed people into the study who had pre-use of dexamethasone. You restricted that to only having a maximum of 6 milligrams use randomization. And then, of course, if they were in the 12 milligram arm, you topped it up. And if they were in the 6 milligram arm, it continued on that basis. And you only allowed a maximum of 10 days delivery of drug. So I think that's all fine. The medians all look fine. What worried me a little bit was the skew. So I've highlighted in red the upper levels of the interquartile range of pre-use and the lower levels of interquartile range on the actual duration of use. So in the 6 milligram arm, I'm slightly worried they had a skewed longer use randomization and also possibly skewed longer use within the trial. 12 milligram group potentially had skewed shorter use and that would have been at 6 milligrams, and potentially skewed shorter use at 12 milligrams in the trial. And if so, then that would push the results towards a null trial as well. So again, maybe by having such a broad use of DEX ahead of time might also have contributed indirectly to you not being able to detect a significant result. So again, maybe worthy of discussion. I'm only working off the IQRs. I don't know the real data, but again, just something to think about. I think also it's just worth saying p-values not all about the p-values. They're a continuum and not a binary threshold. I think you'd find very few statisticians who fixate on p less than 0.05. The journals do, we don't. And, you know, just if it hits one side of the threshold, you're good. If it hits the other, you're not. That is not helpful. And so I think we just need to look at the totality of the evidence. And so looking at mortality, you know, it does look very much as if it is heading in favour of mortality, but the results are very sensitive to one or two cases. So, you know, if you think about the fragility index, which we use to say how fragile are significant results, that would turn them into non-significant results. If we go the other way, actually, if the results had differed by only 3 patients in the mortality group, it would have been a significant result. So actually, we're really quite sensitive to small numbers. And that's even more than your loss to follow-up. And your loss to follow-up rate was minuscule. So I think, again, you know, we probably need to look wider, look to the profile of outcomes rather than fixate on any one, the primary, the mortality. Let's look at the profile. So the outcome profile, and again, this is what Pocock and Stone would suggest you do. Actually, it's not really about the statistical significance of the primary outcome or the secondary outcomes. The interpretation of any trial should depend on the totality of the evidence, the primary, the secondary, the safety outcomes, not just a single endpoint. So for me, looking at the profile, I look to the confidence intervals and not the p-value. They suggest to me consistent direction of effect in favour of benefit and no evidence of apparent harm. Just one last point really about Bayesian. I think a lot of people would think Bayesian analysis will help. Is this a silver bullet? It might add a little bit of insight around the quantifiable estimates, but actually I'm not sure it'll really help because I think there are some fundamental issues at play. I'm not sure a Bayesian analysis will help an outcome that has ceiling effects. It might. And it's not simply about power and significance. We need to really think about what the underlying issues in this trial is telling us. And the Bayesian might give us a little bit more certainty around the probability. So my conclusion then, evidence to me points absolutely towards no evidence of harm and certainly potential benefit of 12 milligrams. The profile of the outcomes support the same message. Consistency across all dimensions adds power to the interpretations. But for me, it's the questions I would think about is what additional evidence would you clinically require to inform your clinical decision making? This is not just a numbers game. And I think maybe we should think, you know, in the short term about non-inferiority. As far as I can see, this is certainly at minimum non-inferior. And so therefore, does that change your thoughts about, well, it's certainly not inferior, would I prescribe it? Economic analysis would also be very interesting. Very, very small additional cost, I would imagine, for the drug, but potentially really high gain in that level of mortality difference. And certainly over time, your combination of knowledge from other studies and your Bayesian analysis and your quality of life will help with the definitive assessment of benefit. But for me, I think at the moment, it's about clinical judgment and decision making. And my last word, there's no such thing as a negative trial. People should not call this a negative trial. This trial is important, it's informative, and it absolutely adds to the evidence base. And I'll just wrap up again. Fantastic job. Well done to the COVID Steroid 2 team. And I'll leave it there.
Marion, thank you. Thank you so much. Fantastic editorial yet again. And you make it look just so easy. A colleague of mine, Peter McGuigan, has tweeted, can we just put Marion Campbell in charge of the world? Such brilliant clarity of thought. It's hard to disagree with that. If you need something new to do tomorrow, you got my vote. We'll go back to the trial team now. Anders, Bala and Sheila, I'm sure you'll want to respond to some of the points that Marion has made.
I may start up. So thanks a million, Marion. I'm very pleased with your comments and your take on this, and I think I agree with all of it. Thinking back, there were, I mean, challenging times when planning this trial. So a new disease handled in a specific way in the beginning of the pandemic, and at least in Denmark, but I think in many parts of the world, the handling of these patients changed somewhat over the course of the pandemic. So we have Danish data from ICUs during the full 20 months of the pandemic, and initially, so in the first wave, 2/3 of all patients were mechanically ventilated, but this changed. So we became more reluctant to put patients on invasive mechanical ventilation, and therefore, in the second wave, only 1/3 of patients were invasively mechanically ventilated. So this changed the population, and I guess that has been one of the challenges potentially with running a trial in a pandemic disease, that the population may change, and particularly the handling of patients may change during that. Regarding the primary outcome, I think we in general struggle a bit in critical care with which outcome to choose as the primary. I think we lack a good outcome that sort of composite adds up to being alive and well. That would be the perfect primary outcome, and we haven't that yet. I think many groups are working on it. We at least will engage more with the patients and society to hear their voice in what they think is a more appropriate outcome. We are a bit concerned about using mortality, as this again will have sort of a biological ceiling effect, that some patients will probably die no matter what you do. Some patient will probably survive no matter what you do. And then you sort of have a middle group that you can intervene against. And therefore, ceiling effect, at least biological, is also a challenge using mortality as the primary outcome. The other comments, the use of dexamethasone prior to randomization. I mean, this was a pragmatic choice. I think if we had said that prior use of dex was an exclusion criteria, we would still run the trial, because sort of the flow of patients, of these patients, is that they come in somewhat hypoxic, get oxygen, get dexamethasone, and then some of them progress. And this is sort of a trial that then enrolled the progressing patients. So therefore, almost all patients were on dexamethasone at the time of randomization. I think it would have been extremely difficult finishing it without enrolling these patients. I'll leave it there, I think. Any comments to that, Sheila or Bala?
I'd like to say thank you very much, Marion. Just listening to you gave me great insights into our trial. Until now, I thought it was just a problem of the p-value, but I really understood a lot of things after what you said. And your point about the pre-randomization use of dexamethasone, I think, is a very important point, where you talk about perhaps the 12 milligram group, receiving lesser doses, and perhaps there was no difference between the arms. I think that's a very important point. But like Prapanna said, it was a pragmatic trial. This was done soon after the recovery study, where people had started using dexamethasone. And because of practical concerns, many patients were treated who would have otherwise normally come into the intensive care unit. Because of a pandemic situation, they were being treated in ward and other areas. So it was not possible to randomize these patients. So a lot of patients got dexamethasone. So in that sense, it was a pragmatic trial, and it would have been difficult to get a patient who had not received dexamethasone because many patients who oxygen dependent were being managed in the ward. But I think this is a very important point. Thank you very much, because this is something that I had not thought about. Thank you. You're muted.
Bala, you're on mute at the moment. There you. Thank you.
Thank you. Sorry. Marion, thank you for that excellent editorial overview. I guess just a few additional points. I think it's also hard to do a blinded trial during a pandemic. There aren't many blinded RCTs, and I guess that's one of the key issues here. And also comparing two very, very different healthcare systems. And if you actually look at the forest plot there, the point estimate for benefit for dexamethasone for 12 milligrams appears to be better in the European cohort as compared to the Indian cohort. And I guess the third key difference was this: probably most of the other trials have stopped at 28 days. And this is the first trial which has gone to day 90, looking at, and there is consistency of outcome benefit. So it's just worth highlighting those. It's hard to know why. I mean, for me, what stood out was really why there was a difference in the 12 milligram effect between the European and the Indian cohorts. But and it'll also be useful to tease out what we haven't got to that yet, the proportion of invasive fungal infections between Europe and India. That'll be a useful additional oversight to get. I'll stop there.
Bala, thanks very much. What we'll do now is we'll bring in my colleague, Chris Nutt. Chris has questions. Chris, I see one from David Harrison on the live stream chat function. I'm sure you'll maybe start with that one.
Yeah, I'll just bring it up. So David Harrison said, days alive and free does not seem to have been calculated / analysed in the conventional way, i.e. death at any time assigned 0. He said 28-day mortality is greater than 25%, but the lower quartile is not 0. And was there a reason for this?
Yeah, that's obviously David is right. He's always right, I think. Yeah, so that's correct. We analyzed all days alive free of life support, no matter if the patient later died, because at least initially we thought that this would add value as well, if not only to patients and relatives, but also to the healthcare system. We did a sensitivity analysis where we counted all deaths within day 28 as 0, and it practically gave the same result. So it didn't change the result to analyze all deaths as 0.
Okay, thanks. Anders, I'm going to move on a little bit. There's a few questions sort of around dosing, and I think Sheila has already elucidated the rationale for the choice between 6 and 12 milligrams. The JAMA meta-analysis used 15 milligrams per day to differentiate high and low dose, and there's also some smaller trial data out there comparing 6 milligrams versus higher doses of methylpred. So was 12 milligrams too low to show a significant difference?
I think that's impossible to answer. I think we will do a subgroup analysis based on weight, and there we may get some insight if patients weighing less will have potentially higher benefit of the drug compared to those weighing more. So that's one indirect way of at least estimating if a higher dose would be beneficial. I think the process of choosing 12 was right, and so I at least I'm still pleased with that choice. I don't know if Bala or Sheila has any comments to that.
I think, look, Anders, yes, it's exactly. It's a very difficult one to answer because, and as you know, there was a survey post recovery, post our first trial that we did. We polled all the clinicians who were taking part in the COVID steroid 1 trial, and there were a range of questions in terms of the interventions to compare, but also the dose. What would be the dose that they would be comfortable with testing? And we know that the ASUS Villar paper looked at 20 milligrams of dexamethasone for non-COVID ARDS. I think clinicians were I think they obviously 6 was really set in stone as one arm, and there was a lot of discussion between 12, 20, and there was a lot of discomfort once we reached the high dose steroid group. Certainly in septic shock, it had been shown to be associated with adverse outcomes, and people weren't comfortable going to the higher end. So we had to settle on an intermediate dose, and 12 was where we got to.
I'd just like to add that in India, we were already using very high doses, doses close to 30 milligrams, I would say, of dexamethasone, even before the recovery trial. So the doses of of corticosteroids use was quite high. And seeing what happened to us in the second wave with the mucormycosis pandemic, which was attributed to using high doses of corticosteroids, we became very cautious about the dose of dexamethasone that we were using. So I think this is definitely a concern in countries where the infection rates are high. You have to balance the efficacy against the risk of serious adverse events, especially infections. So in that sense, I think a 6 milligram versus a 12 milligram was quite a balanced approach.
There has been different approaches to the use of steroids. The Codex trial used an initial higher dose followed by a lower dose. DEXA ARDS, again, sort of similar. Is that something that needs looked at further? Or should we be titrating the dose to the patient in terms of their inflammatory markers? Is there something that needs looked at there? Do we need a COVID steroid 3 trial?
I don't know. It was sort of an exhausting experience, I think, at least. So I personally, I'm not ready to that, but I think there are still many unanswered questions on steroid use in acute hypoxic respiratory failure in general. So to run more platform trials where it will become easier to test different steroids, different dosing regimes, but also the duration of therapy in the sickest patients. I think that would be worthwhile doing. But I think we need more platform trials to do this much easier, to allow us to answer more questions. So more collaboration, more platform trials, then I think we can do it, because there are so many questions to be answered.
And you've talked about the balance between immunosuppression having a beneficial effect and adverse effects in terms of superinfections. The patient population in your trial had there was a relatively low use of IL-6 inhibitors. So have you any recommendations or any thoughts now that IL-6s are in many guidelines and considered a standard of care, whether you should continue with a lower dose or a higher dose in those patients?
Look, again, I think we don't have answers to this question. It's a tough one, and certainly in our own study, correct me if I'm wrong, Anders, I think we only had about 25 or 50 patients overall who had concomitant IL-6 inhibitors. So we certainly can't tease out the data from our trial. It'll be pretty difficult.
Yeah, I think, I mean, obviously the REMAP-CAP trial result came out during our trial, and therefore it's a small population that have been exposed to sort of the combination of higher dose steroid and IL-6 inhibitors. And as Bala said, I mean, there's no head-to-head comparison. I think if clinicians do not have access to IL-6 inhibitors, or the specific patient is potentially inappropriate to the use of an IL-6 inhibitor, I would at least personally consider using higher dose steroids instead. If there's any room for the combination of IL-6 inhibitors and higher dose steroids, I don't know. Personally, I would probably be a bit concerned about that. If there's something nice about steroids in the way that they can be stopped. It's cheap, it's available everywhere. It's very well known to all clinicians, whereas the use of IL-6 inhibitors in severely ill patients is something new. So I could see that many clinicians may actually choose to use higher dose steroids instead of IL-6 inhibitors for those reasons. If that's right or wrong, I don't know.
Anders, thanks very much. Chris, thank you very much. We better move on. We are quite a bit behind time once again. So we're going to bring in our panel now, and I'll start with Bram. Bram, could you perhaps give us your initial thoughts on the trial? And I think you have a little bit of data to share with us as well.
Yeah, thanks, Rob. Fantastic discussion. Wow, blown away by presentation of this amazing trial, the work done to do it during the pandemic, and a fantastic editorial by Marion, who brought up a lot of the points that I think are integral. You know, I work as a guideline methodologist with the WHO, ESICM, Society of Critical Care Medicine, amongst others, and we're often faced with this issue when coming up with recommendations for clinical care with, you know, systematic reviews, meta-analysis that suggest benefit based on point estimates, but with confidence intervals that cross no effect. And, you know, you have to make the best informed decision with what you have often. And certainly agree with the summation that's been made to this point, is that when we look at the point estimates, we look at the 95% confidence interval, and I love that Marion brought up that approach because that's what we use in keeping with GRADE, is that my takeaway from the mortality outcome is my best guess is a 13% reduction in 90-day mortality. Now, I'm not as certain about that because of confidence intervals that at the upper end cross 1, but it certainly seems like my best guess is a reduction. Interesting that around the fragility and the powering, in that, you know, they actually, investigators hit their baseline risks that they were aiming for at 30% and hit the relative risk reduction at about 5% that they were hoping for. Still, because of, you know, post-randomization exclusions and adjustment, didn't quite meet that 0.05. But it makes me wonder so much that if we had enrolled another 20, 50, 100 patients, whether we would be having a much different conversation at this moment if we had. And to Rob's point, I'm just going to share my screen. You may or may not be aware that there were actually, and Anders, I apologize, I don't mean to steal your thunder about ongoing analysis that you're planning from a meta-analysis perspective, but there were a couple of other small trials that have evaluated this question of low-dose steroids versus high-dose steroids. 2, in fact, one from Argentina, one from Iran. They're not perfect comparisons. And so I can't pretend to believe that this is all, you know, homogeneous data that we're pooling here together. One of them was only in ARDS patients, one of the other ones in hospitalized patients. One of them actually looked at high dose methylpred against lower dose dexamethasone. So again, not a perfect comparison. But you can see if you add in an extra 100 or 200 patients from these smaller RCTs, this is looking at mortality at the longest follow-up point using a fixed effect meta-analysis technique, which I think is justified because this is primarily driven by the one trial that we're discussing today, the COVID steroid trial. All of a sudden, this effect estimate does become statistically significant for those that love p-values out there. So, you know, I think that there's a lot of compelling reasons in my eyes why this should influence practice. And again, I'll be honest that it has changed my practice, and we are a center where we use a lot of tocilizumab. And I've still been giving 12 milligrams of dexamethasone to my patients. There's a few areas, very, very quickly, a few areas that I'm still concerned about. The imprecision is important, and I think that we need further data. And that's why I think I also posted on Twitter, this, in my mind, wouldn't be a strong recommendation to use the higher dose, but certainly because of the costs and the other aspects, I think would be consistent with a conditional or weak recommendation to use the larger dose as compared to the lower dose. The changing landscape of usual care is important too. It's not just IL-6 receptor blockers, but we're using more JAK2 inhibitors now. We're not using convalescent plasma. We've learned so much in 18 months that usual care has shifted and will continue to shift in the next few months. And so it's so hard to do research because lessons, trial data that we have from 6 months ago, when it comes to generalizability, is already a little bit stale, and usual care has shifted, and we're not sure how well that applies to our current state. So that's an area of ongoing uncertainty. And then very lastly, and then hand things over to other panel members, is the SAEs. And, it certainly seems like here that there was not an increase in SAEs and adverse events with the higher dose. And that's consistent with RCTs in sepsis and consistent with RCTs in ARDS, for which we've done meta-analysis for. But a lot of these side effects are relatively rare and hard to capture. Neuromuscular weakness, so hard to diagnose in the ICU. Even mucormycosis and invasive fungal infection, very difficult to capture. You'd need thousands and thousands and thousands of patients probably to show a difference. So I still am a little bit worried about SAE, severe adverse events and infection, and I don't think we're going to see the impact of that without many more patients. So for me, I've changed my practice, a weak recommendation in my eyes, but still, as we've said, ongoing areas of uncertainty.
Bram, thank you very much. Fantastic comments there. Very, very interesting. Paul, I'll turn to you, an epidemiologist and non-clinician for those watching. How would you interpret this from a methods point of view?
It was really, really interesting, Robert. Thanks for the invitation to be on the panel. Huge congratulations to Sheila, Bala, and Anders. It was an incredible trial and in really difficult circumstances. And I think the couple of main points really are that are challenges to any study, but I think have been extenuated during the pandemic, both of which have been touched on already and discussed already. But it's really around, I think, firstly, that balance between sort of what would be tight study design controls with an aim sort of to reduce the potential bias in the study. And Bala mentioned the fact that it was a blinded intervention, etc., which is fantastic, and not many, as Bala said, have been blinded within the pandemic. But also the decisions made that have really increased the pragmatism, such as the very broad eligibility criteria and obviously the discussion that we've already had on dexamethasone being allowed up to 4 days prior to enrollment. And these decisions that we all make during design of any study do have potential large implications for the study. Do you allow 12 hours of invasive mechanical ventilation before you can randomize, just to allow windows for recruitment, potentially consent, etc.? Really important sort of design features. Secondly, which Bram just mentioned, is really that changing background care that is happening that can affect the conduct of the study. We've talked, Anders mentioned about, it's been the same in the UK, mechanical ventilation at the start of the pandemic. The vast majority of patients were being mechanically ventilated, and that has dropped off gradually, and a different cohort of patients are now being ventilated. There's far more use of CPAP, high flow in COVID-19 patients, etc. And all these have implications of the interpretation and running of the study. But also it's fantastic about how you reacted to the recovery results. I'd say that is a really key aspect in how quickly you change tack from looking at the initial steroid trial into changing to a high dose versus the low dose steroids. That was really important. But I think the interpretation, obviously, the background of tocilizumab moving into standard care for severe COVID-19 is important, and obviously only about 10% of patients, probably later on in the trial, I imagine, sort of received that. But it's great to see sort of the longer term follow-up with the quality of life and up to 180 days, I think will be really important outputs. Marion touched upon the sort of the benefit of or maybe the reanalysis of the Bayesian approach will be not being a benefit. What may well have been a benefit, I imagine, I'm not a statistician, but it's but maybe the Bayesian or the adaptive approach, which would have had no fixed sample size, and then potentially you would be stopping the study on a statistical trigger of efficacy, etc., rather than a fixed sample size where you're cutting the analysis and then analyzing it at that single point. And maybe that sort of approach may well have yielded what we call a positive result in the study. But overall, it was really, really important, I think, with some huge design challenges that have been extenuated over the pandemic.
Paul, thank you very much. We'll turn now to Colin in Auckland. Colin's joining us. It's not just as early in the morning as it was whenever you started. Thanks very much for joining us, Colin. Colin, you wrote the editorial which has come out in JAMA just a few minutes ago, along with Lisa Higgins and Steve Webb, and there were a few very interesting points in that. One of them follows on from what Paul has just said, and you kind of allude to maybe we should possibly be moving to a Bayesian approach. Let me just see, I have it here. Where did it go to? Oh, it's in there somewhere. I'll not spend time trying to find it. I'll hand over to you. So Paul, so Colin, your thoughts on, does this sort of a trial maybe not force us, but nudge the critical care community towards using more Bayesian analyses?
Yes, well, this trial, first of all, congratulations to Anders and the team. I think it's been a fantastic journey that you've been on, and a great result. And it's good to be having this discussion. So congratulations first of all. On the question of Bayesian, I think this is a great illustration of what can occur when you have to pre-specify various aspects of a trial, determine your sample size at the beginning, and then make your analysis on against those assumptions that you started off with a long time previously. And I don't know if that really helps us it's an approach that pushes us into a bit of a corner. And a Bayesian approach does give us the ability to pre-specify the degree of certainty that we want to achieve in our result. And that's the thing that we pre-specify. And that's really a more clinically useful question. What is the probability that this treatment is better? And if we can set that probability as our pre-specified threshold, then recruitment can continue until and whatever varying outcomes you might want to look as triggers are actually met. And it is possible to do that and achieve an answer no matter what the trial is. You have to keep on going. You have to have the capacity to keep on going until you hit futility or a specified outcome, but it does mean you do get to an answer. And I think that's an approach we will increasingly be taking on board. One of the other things about the design here, and Marion mentioned it, was the ceiling effect of the primary outcome. And I think that's another very important lesson, is that when you've got a scale such as that, where everyone's pushed up at one end, or a lot of the patients are pushed up at one end, it becomes less sensitive to picking up effects, treatment effects. And we have to think very carefully about our selection of primary outcome to help maximize the ability of the trial design to detect treatment effects. Perhaps one other comment I should make, and that's the idea of platform trials that you mentioned, is the ability to look at interactions. And the question about what do we do with this trial when we've also got standard of care moving, becoming IL-6 receptor antagonists in the mix, and where does this fit in? And having a platform or multifactorial trial design that can look at interactions from the very beginning would really help us in answering these questions. We don't tend to give treatments in isolation, we give them in combination. That's the nature of clinical practice. And I think having our trial designs aimed to reflect that can help answer the questions that clinicians really need to know.
Colin, thank you very much. Can I ask you, Colin, just before we move on, and Paul maybe as well, both of you are involved in REMAP-CAP, which of course uses a Bayesian framework. Has that changed how you now view trials? Are you more likely to start trials using a Bayesian framework?
Well, I've become increasingly sold on the idea. We've learned a lot about how to do it through the last couple of years. And I think it's got a lot to offer the clinical trial community. It's got some challenges, and Paul's nodding there, very much so. But I think they're worth it. I think the gains we get in terms of being able to give answers that are more clinically relevant. What is the probability that this treatment is beneficial? It's the kind of question a clinician wants answered, rather than which side of the 0.05 line did it sit. Paul.
I agree with Colin. I'd be interested to know what Marion's thought from a statistician point of view, from talking to our statistician David in ICNARC, is just the planning, the design, etc., is hugely labor intensive in a large Bayesian platform trial. There's also challenges, obviously, as we said, there's potentially no fixed sample size. How do you cost a large trial for a funding application, etc.? There are a lot of, I think, uncertainties, and it needs a funder who will take a leap, I think, and to take that risk in a platform trial.
Yeah, I mean, I can just chip in there. I'm leading a Bayesian trial at the moment, and it's not a bed of roses. It's difficult, but I think you either have to grasp the whole perspective, I think, of the Bayesian approach from day one, and then you're running in that mode. So you've set up the data collection to help you then inform. You need your priors and your posterior probabilities. So if you're in that zone from the beginning, you do a lot of the planning up front, but then at least everything is fulfilling that design. I think when it is difficult is where you've set it up in a frequentist context, and then you're trying to use a Bayesian approach to, sort of almost unpack something at the end of the day. You're trying to unpick. And effectively, you wouldn't be having this conversation, I'm sure, if we were on the other side of the line of p less than 0.05. So it's about, I guess, a second way of trying to get useful information out of it. And I think we should just move more wholesale to Bayesian trials, but we'll need to sort of, I guess, all educate ourselves on the journey. I'm sure if you come back here to critical care reviews in 10 years, we'll have.
Great, thank you, Marion. There's a comment here from Anders Granholm, who I think was the statistician, Anders, for this trial. On the live stream, he has posted regarding the Bayesian analysis, which is currently under review. An important point is that this is not a reanalysis motivated by near significance of the result, but a prospectively planned secondary analysis with a full protocol published prior to any unblinding stroke analysis. So thanks for that contribution. Anders, you mentioned during the ESICM presentation that you were possibly a bit frustrated with the results that has been returned with this frequentist approach, and maybe you might move more to Bayesian analyses and Bayesian frameworks in future.
Yeah, that's I guess the frustration is the lack of nuance in the interpretation, and at least the sort of the conclusions allowed for in the major journals. So a lot of money and frustration could be spared if we just skip the p-value and allowed the more nuanced interpretation also in frequentistically planned trials. Having said that, I agree with the prospects of starting out without a pre-planned sample size and moving towards a degree of certainty. So there, I think the Bayesian framework does have some interesting potential, but when it comes to interpretation, I think we can have nuanced interpretation in a frequently designed trial as well. We just need to drop the p-value and look at confidence intervals instead.
And you wrote a lovely paper in JAMA last summer, I think it was, along with Chris Nixon and Paul Young, about how to potentially interpret trial results that didn't meet statistical significance, and a lot of it was in that. I remember having discussions, and the former editor-in-chief of JAMA, Howard Bochner, has said it, I think, in discussion with Marion, that they will hold trialists to report the results as they said they should, or they will report it. So is it possible for trialists to say, we will report in a more nuanced fashion?
Yeah, I think at least we will do that in the future. So if we plan frequentistic trials in the future, I think we'll put in the protocol and the statistical analysis plans that we will not look at p-values at all. If journal editors at the end of the day will accept that, I'm not sure. It appears easier some way or the other to report a Bayesian trial. There you are allowed a very nuanced interpretation in a journal. So I think a lot of the frustration that we at least have felt in this process would have been less if not only interpreting the results based on p-value of the primary outcome only.
Sure. Bala, you want to come in there?
Oh, look, I mean, it's a fantastic discussion. The p-value is so deep-rooted in the minds of clinicians and, everywhere. So it's just hard to change. And I'm not saying there's not a reason for change, but a more fundamental change will probably need to come at a journal. The high-impact journals will need to start the way they are happy to accept data being reported, almost like a new sort of consort checklist, which a new sort of reporting checklist will need to be developed, which allows people to have nuanced interpretations of results rather than a conventional p less than 0.05.
Sure. And Sheila, perhaps you'd like to come in on this as well?
Yeah, very interesting discussion. I agree with what has been stated, but it's hard to get people to not look at p-values. But this is definitely something new and interesting and perhaps futuristic, and will change the way we look at trials and have a more nuanced interpretation. This was definitely a frustration for us, seeing the way the results turned out. But like Marion said, that if it had been the other way around, perhaps we wouldn't be having this kind of discussion. So it's just the way we look at it. Yeah, I agree.
And Bram, you want to come in on this?
No, I'm so reassured to hear a discussion around, hear such an amazing group of methodologists, trialists, and a general agreement that, slave to the p-value is not necessarily always the best approach. No doubt, I think at the same side, it can be a slippery slope, and we certainly want to avoid overinterpretation of trends and this sort of thing. So I think p-value gives the journals that anchoring to avoid, misinterpretation of study results, but there has to be some other framework that we can come up with that still recognizes situations where there is uncertainty, does not overinterpret study results that don't need to be interpreted, but still recognizes that a p-value, with confidence intervals that just hit no effect or just go over might still be important for management. And so I think that that's where there's risk obviously with it, but there has to be a nuanced way of doing this and a nuanced way of presenting it to readers.
Sure. I think Paul and Colin both want to come in. Paul?
I was just going to make the point that I think it also depends, the nuanced interpretation also depends on the potential risk of the intervention that you are evaluating. So a low risk intervention, etc. You would take your something where the confidence interval does cross one, you may be more confident about. I think Marion said it on the non-inferiority sort of aspect, that some interventions you may well push more on the non-inferiority or happy with the non-inferiority sort of side, rather than a more risky, with potentially more side effects. You would be more reticent about interpreting that a confidence interval that still crosses one.
Yeah, it's definitely the very reassuring adverse event profile in this trial is very helpful in this regard, and it does enable us, I think, to move more confidently in the direction of higher doses because of that safety profile. So that's been a very good part of this. I think we can learn to not look at p-values. I think we'll just have to get used to the idea of posterior probabilities and which level of confidence we're happy with. And we do aim for pretty high probabilities when we're doing that, well into the high 90s, I think is kind of where people are comfortable with. And I think we can make that change.
Sure. Anders, you're going to come back in.
Yeah, but because I guess the case about uncertainty in a trial where it's so easy to assess and quantify the uncertainty for the statistical part, the uncertainty when it comes to risk of bias and generalizability is much more difficult to quantify, and therefore we probably discuss it less. So more of the discussion around trial interpretation should be around internal and external validity, which cannot be quantified, and therefore obviously it's more difficult to discuss it. But I think that's, for many trials, is much more important than if the p-value is 4% or 7%. But we have presently very limited framework to sort of quantify and therefore discuss the uncertainties that lies in internal and external validity.
Yeah, I think Andrew Althouse, a statistician from Pittsburgh, we've been fortunate to have on with us many times before, made a point similar to Paul's, that basically the risk with Dex 12 milligrams doesn't appear to be high, and therefore it may well be a very valid thing to move to using 12 milligrams of dexamethasone. Jay Nesbitt, frequent contributor to us, has made a nice comment on the live stream chat function. Interpretation of the nuances remain very difficult when we teach stats a particular way to med student, postgrad grad students and beyond. So if we move into a more nuanced era for interpreting trial results, how do we teach that? How do we get that across? Because I mean, we're lucky tonight, we have real expertise. We have statisticians, methodologists, epidemiologists, trialists, but most of us clinicians don't have those skill sets. Bala, perhaps I'll turn to you with that.
Sorry, I was just getting a hospital call there for a second. Sorry. The last question, I missed the last point.
Sorry, so I was just reading a comment on the live stream chat function. A colleague in England, Jay Nesbitt, interpretation of the nuances remain very difficult when we teach stats a particular way to med student, postgraduate students and beyond. So for me, we move into an era where we start with much more nuanced and appropriately nuanced interpretation of trial results. How do we teach everybody that? Because the majority of us trying to interpret these results are clinicians without a great background in statistics, unlike the panel we have tonight, an expert panel.
I think, Robert, it's an important issue, and I think the training needs to commence at a very early stage. A number of us don't get exposed to even being taught evidence-based medicine till well into the training pathway. And very often people start to do this when they're doing their trainee projects. And I guess having these sorts of training modules at a medical student level, and then and obviously once you know, a different type of reporting becomes mainstream and people being able to attend journal clubs, and where it's all it's all discussed in a different way in terms of posterior probability and Bayesian methods. I think that's the only, I think it's just going to take time, and it has to happen from medical student, trainee, at every journal club, at regular scientific meetings, and then it becomes the norm.
Sure. I think, Marion, you're going to come in there. Just before you come in, a similar comment along those lines. I was reading one of those lovely BMJ statistic articles from a few decades ago. It was Doug Altman, and he was basically implying that a p-value of 0.04 should be interpreted pretty much a very similar way to a p-value of 0.06. And maybe we need to get that sort of information out to clinicians and the bulk of the healthcare workforce who are working on these trial results, who don't have your expertise.
If I could just chip in, I think it's really important that the training that's given to clinicians is more nuanced. Because actually, you know, it's quite often statisticians teaching, and statisticians don't have a dichotomy around p less than 0.05, and yet somehow it's sort of gone into the teaching that might be the quick rubric. So I think what we should be moving to teaching is work with your statistical colleagues from the start. I think it's all about partnership working on everything. And therefore, you know, it shouldn't be down to the clinician to make all the decisions, including on the stats, and it shouldn't be the statisticians having to sort of plough a furrow. So I think the quicker we move to saying actually what we need to teach is team science, I think that would really be helpful. You're muted, Rob.
Colin, can I ask on this theme, have you changed now to using 12 milligrams of dexamethasone, or are you still using 6? Or do you have a nuanced answer?
I think it's going to depend on the clinical circumstances. I think, as pointed out, the situation with interleukin-6 receptor antagonists as the current standard of care, and we don't know really where 12 milligrams fits in alongside that. I would say in the current global shortage, we may find that patients who are either unable or for whatever reason to have it, then I think there's going to be a clear alternative, I think now, given the safety profile here and the very strong signal for benefit. So in the absence of availability of interleukin-6 receptor antagonists, I think it would definitely have a place. Alongside it, I'm a lot more uncertain, I think. That's probably as far as I could go at the moment.
Okay, and Sheila, can I ask, have you started to use 12 milligrams of dexamethasone as opposed to 6?
Yes, we have, but not across the board. In patients who are receiving IL-6 inhibitors, we're still using lower doses. But again, there is a variation practice, but there is a trend towards using higher doses because we have seen a trend towards a benefit without any increased risk of without any difference in adverse events. So there is more confidence definitely to use 12 milligram. But with patients on IL-6, I'm not sure. People still tend to use 6 milligram of dexamethasone.
And Bala, you've been fortunate in Australia. You've avoided much of the worst of the pandemic. Have you started to use 12 where you would previously have used 6?
Look, thankfully, but also, of course, in Queensland, we have got no COVID. So I've not had a chance to use dexamethasone for some time. But if it does happen, then I would be using 12.
And Anders in Copenhagen?
Yeah, we have used it for some cases, mainly patients that could not, for medical reasons, were not less appropriate for medical reasons to receive IL-6 inhibitors. So we have used it.
Okay, we're going to start coming towards the end of the discussion. So I'm just going to get one or two last questions. Paul, there was a comment from a colleague of yours. Where is it gone to? It was about using a 2-arm trial to answer a dose-finding question. Maybe some of the other panelists have seen that on Twitter as well. Should a different sort of trial design have been used?
I mean, a different trial design could have been used, but I think, again, this could well have been, there are different adaptive approaches that could have been used, I think, such as randomizing to multiple doses. You could be adapting by dropping doses as you're going along, for example, through interim analysis. So there are more, but it's whether this was really a dose finding study or current standard of care against a more high dose, which was, I'm not sure it was quite a dose finding study itself.
Sure. And Bram, can I ask, and I might need Sheila to come in on this, or Anders or Bala, does the timing of this trial make a difference? Was this trial pre-Delta wave, and does the the nature of the variant or strain of the virus at a time make a difference?
Interesting hypothesis. I'm not convinced, and you know, from my perspective, is that I think no matter the variant, is that the pathophysiology in terms of ARDS manifestation and the biologic rationale for any effect that corticosteroids are going to have on decreasing inflammation in the lungs and inflammatory cytokines, et cetera, is going to be synchronous and consistent across variants. In fact, you know, we published in ICM fairly recently. I'm fairly convinced that this lesson learned around dosing and benefit of corticosteroids, as we saw in DEXA ARDS, applies to other etiologies of ARDS too. And, you know, the whole world is now treating ARDS from COVID with steroids, but still much reluctance of treating non-COVID ARDS with steroids, despite positive results. We see much more variable practice. And so forget variant. I think, I know ARDS is a heterogeneous entity with multiple triggers, and I don't underestimate that, but the end result in terms of pathophysiology is in alveolitis and inflammation. And I think steroids are beneficial for ARDS, full stop.
Super. Okay, we're coming to the end. So what I'm going to do is I'm going to quickly go around each of the panelists for a final few words. Colin, you're the furthest away, all the way out there in beautiful Auckland. I'll start with you, please.
Well, I think overall we've had a great discussion, and thanks for the research team for you know, bringing this forward. We've got another important step on the journey of optimal treatment for COVID-19. Still many questions to come, but I think thank you for taking us another step along the journey. But also, I think this discussion has illustrated we're also moving along a journey of trial design and how we can best utilize our skills to find answers that are useful for clinicians. And I think that's as much part of the journey as well.
Super, thank you. Paul?
I couldn't agree more. Huge congratulations to the trial team, and thanks to Rob and all the panelists and Marion for the wonderful editorial. It's a great panel and a great sort of forum to discuss these really important studies.
Yeah, it certainly is a superb panel. Bram, in Canada, any last comments about this and our interpretation?
None, Rob. Just humbled to be a part of this group and be able to share my insights, and very appreciative for the invitation. Thank you.
Thank you. Marion, final thoughts?
Final thoughts are, I'm sad that Anders feels disappointed. I think that's my last thing. This is not a negative trial, and we need to take the positives from it and learn from it, and well done.
Sheila?
Thank you very much, Rob, and the Critical Care Reviews team, and Prof. Perner and the COVID Steroid 2 team for giving me the opportunity. This was a very important trial for us to do in India. You know, doing a randomized controlled trial, it's across so many sites, and leading this in the midst of a pandemic was really a challenge in India. And it was very interesting to do this with the Scandinavian countries and other European countries and India, where the infection rates, the setting, and even the healthcare infrastructure is so different. So this was very exciting for me. And I think the results are very important, especially for India after the Delta wave and the increased cases of mucormycosis. This question was, to have this answer was very important for us about the dosing. So I was very happy to be a part of it. And thank you, all of you. Thank you.
Super. Bala, your last thoughts?
Rob, thank you. Look, firstly, it's been a great privilege for me to have been part of this team and to have worked on this trial. Just to add, one of the questions you asked was about the Delta wave question before. In fact, the Delta wave sort of kicked off in India sometime in February, March. And that's when the enrollment actually into the trial jumped big time. So, and the enrollment did not complete. The last patient was randomized on the 24th of May. So there were about 3 months where the Delta wave was rampant in India and a number of patients were enrolled in India. So I think hopefully that we had a number of pre-Delta variants as well as post-Delta wave patients coming into the trial. But I think the other key thing is, having done the trial in several different healthcare systems, I think increases the external validity of the trial. I think that's a very important, and the consistency of results across the regions is very important. And so I'm confident this trial will change practice.
Thanks, Bala. And of course, we'll have Bharath Kumar joining us in just a moment to discuss the challenges of undertaking research during a pandemic and the experiences he and Bala have had in running the HOPE trial. So we'll finish this section of the live stream with Anders, who of course led the CS2 trial.
Thanks a million, Rob, and thanks for hosting us, and thank you for everything you do for the critical care community. That is truly amazing. So thanks a million, guys. I love this discussion, Marion. I'm not disappointed. I was frustrated with the publication process. That's all. I'm a very happy man. I have new friends in India. It's been amazing to work with Sheila and Bharath and all the colleagues there. I sincerely hope that we can continue to do trials and research together and build an even stronger friendship. Thank you to my old friend Bala for being part of this and helping to liaise between Europe and India. Thank you to the panel. Thank you to not everyone, but almost everyone, including the full team at all sites, the team at the George Institute and Craig. So I'm a very happy man, Marion, no worries.
Fantastic. And of course, the paper is out in JAMA along with Colin's editorial written, as I mentioned, with Lisa and Steve Webb. So if you haven't yet seen it, please go to the JAMA website, download those and have a read. Fantastic articles.